Right. Hi, everybody. Okay, welcome to Is It ADHD webinar with Jess Eccles. The content for this evening, going to do some very, very quick introductions now and try and catch up on a bit of time. A very brief now, introduction to neurodiversity. Then it's straight on to the main attraction, which is Jess Eccles. She's our patron and guest this evening, and I'll tell you a bit about her in a sec. We'll have a comfort break round about the halfway mark, which is going to be about 8-ish. I'll have to adjust that slightly possibly now, but we'll have a break, okay? And then we'll go back to Jess to finish off her part of this. And then probably one of the best things of the evening is we're going to have an open Q&A. I've already got some questions that people, you guys and girls, etc., have put to me. And I'll put those to Jess. But as I say, you're also welcome to come on camera, and then we'll do some announcements at the end. Okay, your host and guest speaker, I'm Martin Bunker. I'm your host for this evening, and we got there in the end. I say 1,000 apologies for that. And we've also got Jess Eccles, Dr. Jess Eccles, who's our guest speaker. Quick bio for Jess. I don't normally read off the screen, but I will do this time. Dr. Eccles, she studied medicine at Cambridge and Oxford, no less. She's a researcher and a neurodevelopmental psychiatrist, try saying that in a hurry, specializing in the links between brain and body, especially as they relate to flexible joints, hypermobility. As well as her university position, she works in the Sussex NHS Neurodevelopmental Service, where she and her colleagues have set up the world's first neurodivergent brain-body clinic. Wow. And she's been working with the intersect between hypermobility and neurodivergence since the first came to work at Brighton and Sussex Medical School in neuroscience in 2009. And alongside all things brain and body and ADHD and neurodiversity, she's also interested in photography. So that's Jess in a mo. Okay, just quickly, I'm just going to try and catch up on some time. Just tell you a bit about ADHD Aware, so you're aware of who we are. We've been around since 2011, just started off in a pub with a group of ADHD people trying to sort the world out and their issues, problems, and everything else. Officially, ADHD Aware was founded in 2015, and we became an official charity in 2021. Just tell you what we do, and I'll go over this a bit at the end, so I'll be quick for now. We do provide peer support meetings. We have a mailing list. Please join that, and I'll tell you about that at the end. We do webinars, such as this amazing one this evening. We also run courses. We have a website, and we also do neurodiversity training in the workplace too. We're user-led, pretty much entirely volunteer run. There's about 30 of us. Around 90% of us are neurodiverse, and myself and some of the others, I've been around for only probably about 3 or 4 years now, but in that time I've met hundreds, if not thousands of users. So we've really created a wonderful neurodiverse community. Okay, very brief. I'm going to skip some of this to catch up on some time. Yep, I'm just going to quickly do the meaning of neurodivergent for those of you that don't know. Neurodivergent is a term used to describe people whose brains operate differently from the typical or average. And I will do this one. Paul, if you wouldn't mind just starting this. Yeah, if you wouldn't mind, I'm just gonna, this is completely up to you if you want to join in, but I just would like to get a feel for if everybody can answer if they
Martin,
think.
unfortunately, there's no
Yeah.
polls available.
Oh, okay. Oh, right. Okay.
So I don't think that's going to happen.
Okay, no worries. Okay, thanks, Paul. Okay, so we won't do that tonight. Yeah, it's because we've joined a different meeting. So apologies for that. Okay. In that case, just quickly, I'll give you the main headings for what neurodivergent is, because I think that's really, really important. So we've got dyscalculia, which is an issue with numbers, for example. We've got dyslexia, which I'm sure you know is an issue with reading and writing. So it's words, words. Good old ADHD, Tourette syndrome, dyspraxia, which is also known as DCD, or developmental coordination disorder, and that's to do with movement coordination. And last but definitely not least is autistic spectrum disorder, ASD. Asperger's has tended to be dropped as a term, but I know a lot of people use that, so I've left it in there. Okay, I'm going to skip the quiz, but I will tell you and show you the prevalence of neurodivergence in children and adults in terms of ADHD. I don't know if it surprises anyone. It's roughly, so ADHD in children is roughly 5% of the population. The prevalence of ADHD in adults goes down to 4%. So there isn't a huge change, but it does, there is a difference. ASD or autism is about 1% of the population, and dyslexia is 10%. I don't know if that surprises anyone. Anyone shake their head, or if that's a surprise, but I thought I'd pop that in there. Yeah, we won't do the quiz. I'm going to move on actually to Jess at this point, I think. So I will unshare my screen. Okay, and I'll pass you over to our amazing guest speaker, Jess Eccles.
Hello, thank you for your patience.
Thanks, Jess.
And I'm just going to share the screen. Hopefully should be okay. You can see the screen now, I suppose. So I'm going to talk to you today about the co-occurrences with ADHD. And as I said, well, as Martin said, I'm really lucky to have a dual role in that I work 3 days a week at the university, the medical school, doing brain body research, and I work for 2 days a week in the Sussex Neurodevelopmental Service. If you want, and we can put this in the chat or what have you later, if you want to follow me, I have various videos, resources and things at, I'm on Twitter at Bendy Brain and on Instagram as Dr. Bendy Brain. So just, well, I've just sort of briefly introduced, but I've been at Brighton Sussex Medical since 2009, where I was really grateful to work with Hugo Critchley, who, as some of you may know, has been working in the neurodevelopmental service in Brighton since its inception. And he introduced me to this topic about hypermobility. And this has led to thinking about neurodivergence and other things. So I'm going to talk you through the research journey in many ways. But I wanted to, before we start really, I wanted to explain to you what my philosophy is. And this has been handily represented in this newspaper headline. The big idea, should we drop the distinction between mental and physical health? And the idea is that the current false distinction actually holds back research, holds back clinical practice, and stigmatizes patients. So I've been on something called an integrated academic training pathway, basically since medical school, where I did another degree in between my clinical and preclinical and clinical training. And ever since I've graduated from medical school, I have combined my clinical practice with research. I took 3 years out to do a PhD, where during that time I worked in the neurodevelopmental service 1 day a week. And I'm now, I've become a consultant, and I have a university position. So the traditional view, and some of you may have been diagnosed under this view, was that these conditions, what we now think of as ND conditions or neurodivergent conditions, were discrete things that you either got diagnosed with ADHD or as autistic, that they were all, inherently disordered, and this view has been changing. So it's perfectly possible now to have multiple diagnoses of neurodevelopmental conditions. When I was at medical school, which was a long time ago now, I was taught that autism and ADHD were much, much more common in males than females. In fact, I was told that autism was 9 times more common in males than females. We had quite stereotyped ideas about, especially about how autism presents, but we were basically sort of taught that autism was small boys who were obsessed with bus timetables and Thomas the Tank Engine, and that ADHD was disruptive boys who threw chairs around in classrooms. We were also taught, which we now know is not true, that autistic people lacked empathy and the ability to theorize other people's minds. We know that there are differences in empathy and mentalization, but they are not absent. We were taught that autistic people couldn't, socially communicate, and we know that that is not true. And what I've really been learning is that co-occurrence is the norm rather than the exception, both in terms of other ND conditions and also with certain physical health issues. And that I think the discussions that we have, the language that we use around these things is important, but everyone has different preferences. So my preference, for example, is to talk about autism rather than autism spectrum disorder. But different people have different preferences, and that needs to be respected. So the alternative view is that neurodivergent conditions actually confer both challenges and strengths, and that being neurodivergent means that you have a brain that just behaves, learns, and processes differently from the typical majority, but that actually neurodivergent people may have considerable strengths in terms of attention to detail, creativity, intuition, thinking outside the box, and that all of these conditions overlap far more than we ever thought. This is actually a slide from another charity that I am a patron of, SEDS Connective, which specifically focuses on the intersect between hypermobility and neurodivergence. So when I think of neurodivergence, I think about it across a variety of domains. So some differences in executive function, which may manifest as impulsivity, differences in social communication, sensory processing, self-regulation through sensation seeking, stimming, self-soothing, compulsivity, interest, and preference for routine. Now, not all people will have all of these things, but these are various domains that are involved. And I want to show you just how pervasive some of our stereotypes are. So this is research from as recently as 2020 that shows if you have, so for children, schools are pretty much gatekeepers for getting diagnoses. And what they found was that if you put exactly the same vignette, so exactly the same information about a child, but you put a boy's name on the case, they were more likely to be put forward for an assessment than if you put a girl's name. And what we know now from research is that actually it's probably likely that there is no discernible sex difference between in neurodevelopmental conditions, and they probably equally affect females as males. And of course, we know that gender is much more complicated than that, and that is another interesting topic. So the other thing is, this paper is focusing on autism, but I think it's relevant for neurodivergence in general, is we know that neurodivergent people experience barriers to healthcare and self-reported adverse outcomes. And some of that may well be to do with systemic and societal difficulties. 80% of autistic adults reported difficulty visiting a general practitioner. And we all understand how that can be. But people do seem to not be served well by the healthcare system. And I wanted to stress how the other problem we have, not only do we have the division between the brain and the body, but in mental health services, we have the division between specialist services and community mental health services and primary care services. And research suggests that possibly about 1 in 5 people attending general adult outpatient psychiatric clinics may in fact be autistic. And I think that figure could be even higher for ADHD. The other thing is, as Martin alluded to, is that the overlap with other neurodevelopmental conditions is really common. So if you're autistic, nearly 70% of autistic people also have ADHD. In Tourette's, which is woefully underappreciated, understudied, under-researched, and underfunded, 60% of people with Tourette's have other neurodevelopmental conditions. 4/5 of autistics have dyspraxia, and 1 in 2 people with dyspraxia have ADHD. And almost all of the people we talk to in clinic, so in clinic, we do ADHD and autism assessments and sometimes Tourette's assessments, sometimes all at the same time. Many people report difficulties that could be related to dyslexia and dyspraxia. So difficulties tying their shoelaces, learning to tie their shoelaces, learning to use a knife and fork, learning to ride a bike, learning to drive a car. Lots of people struggled at school, and maybe they were diagnosed with dyslexia, but that was before people were really understanding how ADHD and autism presented. The other thing that our service has sort of changed over the years, because as I said, I first started working in it in 2012 and then again in 2014, and then became a consultant in the service in 2020, is that we're really trying to take a neurodiversity affirmative approach, emphasizing people's challenges, but also their strengths, and really trying to support people to thrive rather than thinking, oh, I am diseased, I am broken. And this is a book that came out last year. Surprisingly, in Ireland, they don't actually have much in the way of autism and ADHD services, but they've written a book about how to take a neurodiversity affirmative approach in autism assessments. I think it would be great if we could write one about ADHD as well. So what I'm here to talk to you about is we've explained how ADHD is often not just ADHD in terms of other ND conditions, but really about all the other things that neurodevelopmental conditions are associated with. So this has really been a series of what I think of as light bulb moments, and really inspired by my my work with working with Professor Critchley, who first, I was diagnosed as hypermobile at medical school on a ward round where an orthopedic physician told me I had sway back knees. But when I came to Brighton and Sussex Medical School, I didn't really know what I was going to research. And Hugo said to me, have you heard of hypermobility? And I was like, well, actually I have, I am hypermobile. And this has really led to, as I said, many years now, 15 years this year of interest in hypermobility. So for those of you who are not aware, hypermobility is typically thought of as a unusual range of motion in the joints. And as you can see, hypermobile people may be able to touch their hands on the floor without bending their knees. As I was identified at medical school, they may have knees that bend slightly backwards or elbows that bend slightly backwards. They might have fingers that go up at the ends. They might be able to do these yoga positions or sit in the W position, particularly as a child. But hypermobility is really much more than joints. And those joints that I have shown on the screen here, they're not all of the joints in the body. There are things like shoulders, hips, ankles that can be hypermobile and people don't necessarily pay attention to. So hypermobility is actually far more than flexible joints. It is a difference in the building blocks of the body, so connective tissue. And connective tissue is everywhere in the body. So hypermobility is in fact relatively common and can be advantageous. So it's really pretty essential if you want to be a ballet dancer or gymnast or tennis, certain sports, but it's actually linked to a variety of medical issues. And because connective tissue is everywhere in the body, these issues cross systems and they involve both the body and the brain. And one of the real problems working in this area or trying to get help in this area is that it's alphabet soup. If we think it's so confusing with terms like ADHD, ASD, DCD, it's really confusing in hypermobility where you have JHS, HEDS, HSD, GJH, GJL. It just goes on and on, the list. And it means that it's hard for people to get access to the treatment and the support that they need. And also there is no established or recognised hypermobility pathway within the NHS. And rheumatologists who typically diagnosed hypermobility is sort of often saying they only look after inflammatory rheumatological conditions like lupus or rheumatoid arthritis. So although in our research we have used some of the physical examinations as part of the research, and some of you may have actually taken part in the research in Brighton, there is actually quite a straightforward way of thinking that someone might be hypermobile. So there's a caveat here, which is a bit like taking a lateral flow test for COVID. It is possible when you take a lateral flow test for COVID that the little line will come up and you don't actually have COVID. But it's also possible that the line doesn't come up and you do have COVID. And that is the problem with all screening instruments. But essentially, if you can answer 2 or more of these questions positively, it's highly likely, sort of 80–90% likely, that you are in fact hypermobile. So can you now, or could you ever, place your hands flat on the floor without bending your knees? Can you now, or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? Do you consider yourself double-jointed? And what we know, as I said, is that hypermobility is so much more than joints. So this is just a list of medical things that are associated with hypermobility. So things like flat feet, fibromyalgia, soft, stretchy skin, stretch marks, hernias, gum problems, a whole variety of gastro issues, so reflux, difficulty swallowing, unexplained abdominal pain, Raynaud's, varicose veins, heavy periods, irritable bladder, squints, dental pain, gum disease, temporomandibular joint pain, thermal pains. And then where I got interested in the topic, things like abnormalities of the flight and fright nervous system, dyspraxia, sensory sensitivities, fatigue, anxiety, the list goes on and on. So we've been thinking about the relationship between the body and the brain, and we've been talking just now about the body. Remember the big idea. We should drop the distinction between mental and physical health. And we should also consider, is joint hypermobility an advantage, or does it have disadvantages? It's essentially something that can have strengths and can have challenges, just like neurodevelopmental conditions. So our first work that we did really was thinking about the relationship between joint hypermobility and anxiety. And this is really interesting. So I think it's interesting. In the 80s and 90s, a group of Spanish researchers, they wrote quite a bit about the link between anxiety and hypermobility. So if you took a room with 100 people who experienced panic attacks, you would find that about 70% of them were hypermobile, compared to about 20% in the general population. And then there was also interesting research from Spain that suggested that if you were hypermobile, you were more likely to smoke, more likely to drink, more likely to eat chocolate. And the authors said they thought this was perhaps a way of managing anxiety. But I wonder now if maybe it was a way of managing ADHD. So the first thing that we did when I was at Brighton and Sussex Medical School and came to work with Hugo was he said, look, we've got these 72 brains. Can you divide them into hypermobile and not hypermobile? This is people who have gone through the brain scanner. The brain scanning department at the medical school had only just opened at this point. And so we classified the brains into hypermobile or not, according to how people scored on the Baton score, which is one of the hypermobility scoring systems. And we found that if you were hypermobile, you had differences in a part of the brain called amygdala, which is to do with fear and emotion processing. And perhaps that was related to anxiety. So I spent my PhD really trying to work out how you get from having flexible joints to being more likely to have a panic attack. And we found that there was a commonality with a physical condition called postural tachycardia syndrome. I don't know if you have heard of it, but postural tachycardia syndrome is when you go from lying to standing, you get a heartbeat rise of about 30 beats per minute, and you feel dizzy, lightheaded, palpitations. This can also happen after eating a large meal or being in a hot environment. And what we postulated, and it's a pretty clunky title, neurovisceral phenotypes and the expression of psychiatric symptoms, was that being hypermobile means that you have floppy connective tissue. And this connective tissue is throughout the body, but it's also in the vasculature. So, the veins. And this means it's harder when blood is moved to one part of the body, such as when you go from lying to standing, for blood to return to the heart. And that means that according to the laws of the body, homeostasis, that when the blood when it's pooled in your feet and isn't coming back to your heart, your body responds by raising your heart rate and sometimes dropping your blood pressure. And this sets off a flight or fright nervous system reaction that may prime you for anxiety. We also did some research, only published actually last year or the year before, where we looked at all the 14-year-olds born in Bristol and Avon in the early 1990s and found that if you were hypermobile at 14, you were more likely to experience common mental health problems at 18, such as anxiety and depression, and that this was in fact related to your resting heart rate. We've written about the transdiagnostic, so across conditions, the relevance of hypermobility to neuropsychiatric symptoms. And as we know, going back to hypermobility, we were thinking, what are the commonalities between hypermobility and neurodevelopmental conditions? So, sorry, I'm going to have to cough. So, in ADHD, abnormalities of the flight and fright nervous system, dysautonomia is reported. ADHD and autism, pain is reported. Pain is a common feature in hypermobility. The overlap with dyspraxia, so studies showing that hypermobile children more likely to have dyspraxia. Lots of people, ADHD people, autistic people, have anxiety, and we've already talked about the link between hypermobility and anxiety. And then, so we'd been wondering about this, especially since we did the brain imaging study. We found differences in areas of the brain that were also found in ADHD and autism. We decided, well, what we're going to do is we're going to look at the Sussex Neurodevelopmental Service and see how many of our neurodivergent patients are in fact hypermobile, and whether they have pain and whether they have differences in the flight or fright nervous system. But whilst we were doing that, we were sort of pipped to the post. Well, we weren't pipped to the post, but a group in Sweden where they have really good health records basically found that if you had a hypermobility diagnosis, you were 7 times more likely to have an autism diagnosis and 5 times more likely to have an ADHD diagnosis and 3 times more likely to have a bipolar disorder diagnosis. So other colleagues around the world, Carolina Bieza-Valesco, were writing about ADHD and autism separately and about the relationship between hypermobility and pain. So what we did was we were able, finally, in 2022, in fact, to publish our findings from the Sussex Neurodevelopmental Service, the research that we conducted. And this paper is open access, so it's freely available online. And in fact, it's now been viewed over 100,000 times, which I think is pretty impressive. But it's mainly, I think, patients and other people in the community. So what we did was we took, whilst I was doing my PhD, we invited people who were attending clinic to take part in a research study where we examined them for hypermobility, and they also filled out a questionnaire about physical symptoms. And what we found was that in the neurodivergent group, we compared them to another group, the comparison group, and also to the general population. We found that if you were neurodivergent, you were 4 times more likely to be hypermobile than our comparison group. And as you can see from the graphs, the neurodivergent people are in red and the comparison group are in bluey green, that they had higher musculoskeletal symptom profiles and higher number of symptoms suggestive of abnormalities of the autonomic nervous system, orthostatic intolerance, the problems of going from lying to standing. And they also had higher hypermobility scores. And what we see here is, although I said that hypermobility was, if you were neurodivergent, you were 4 times more likely to be hypermobile, we can see that in our female neurodivergent participants, this is on the graph on the left, nearly 80% of them were hypermobile. And that the hypermobility score tracked with the flight and fright nervous system score and with the pain score. So what we were trying to work out is all of these things seem interrelated, but what does that mean? Just because something is related to something doesn't necessarily mean it is caused by it. We did some mathematical modeling to see if we could work out what was driving this relationship. And this is what we found, that if you were neurodivergent, you were more likely to experience physical health symptoms, and this was because of hypermobility. And it really made us think, if we're seeing neurodivergent people, we must think about hypermobility. And if we're seeing hypermobile people, we must think about neurodivergence. And I've been giving talks about this for some time, and I get quite a few emails from people, and someone emailed me and they're like, it's all very well saying that you've got to look for these things, but what if our services, our support networks, our schools, if they're not accessible for neurodivergent people or hypermobile people? And that is really important. So what could be driving this relationship? I've told you about how hypermobility and anxiety may be related, but it's a little bit trickier to work out about how hypermobility and neurodivergence may be related. And I think that really at its heart, the connective tissue is influencing sensory processing, and sensory processing is so important for so many things, including attention. And what we found in a study of 110 people with hypermobility was that the greater the number of connective tissue features, so the greater the bodily involvement in hypermobility, the higher the sensory processing score was on a autism screening scale. So I think we're just shortly to pause for the break, but we need more research into why this relationship exists, more recognition and awareness, and improved access to healthcare that is specifically looking at the individual differences in a person. I want to talk to you now about chronic pain and fatigue. So myself and colleagues at the medical school, when we were doing our work about the flight and fright nervous system and hypermobility, there seemed to be a lot of interest in dysautonomia, the abnormalities of the flight and fright nervous system, in fibromyalgia. So we decided that we would conduct a study about fibromyalgia and ME/CFS. And as part of that work, myself and the rheumatologist, Professor Kevin Davis, we wrote a review article about the difficulties and the challenges of chronic pain and fatigue. Because some people, mainly in Europe, and often think that fibromyalgia and ME/CFS are a sort of not psychosomatic condition, are sort of some kind of manifestation of psychological distress. And we didn't really think that that was necessarily the case, that there was actually lots of work that was linking the biological things in chronic pain and fatigue. And common features were things like hypermobility, something called small fiber neuropathy, mast cell activation, which is an allergy response, and dysregulated inflammatory and interoceptive processes. And many people with chronic pain and fatigue also experience postural tachycardia syndrome. And there was an increased awareness about this because of long COVID. Lots of people with long COVID seem to be developing postural tachycardia syndrome. So we wrote about this article. Oh, the QR code is gone, but I'll be able to send it to Martin. So what we did, this was before we'd written the article, is we designed a study in which we were going to have 25 people with fibromyalgia who had pain and pain only, and we were going to compare them to 25 people with MECFS who had fatigue and fatigue only, because that's what we thought, that's what we were told in the textbooks. And then we were going to compare them to people without pain or fatigue. And of course, it wasn't as straightforward as that. But what we wanted to do was to see if there were two things that made pain and fatigue worse. So how pain and fatigue were influenced by the autonomic nervous system, so the flight or fright nervous system, and we were to do that by putting people on a tilt table. And we were also interested to see how pain and fatigue responded to inflammation. So we invited people to come to our brain imaging center where we took pictures of their brains, one day with a saline injection and one day with a typhoid vaccination. And we did all sorts of tests and blood tests and all sorts of things. And I'm going to give you some results about what we found. And you might be thinking, how is this relevant to ADHD? But I'm getting there. So first of all, what happened is we actually found it quite hard to find patients who only had pain or only had fatigue. And, you know, we should have known that. So about 30% of people, the patient participants who came to the study, about a third of them had fibromyalgia diagnosis, and a third had an MECFS diagnosis, and a third had both. But what we found when we actually analysed it was that nearly 90% of the patients actually had fibromyalgia or met diagnostic criteria for fibromyalgia, and nearly all of the patients, whether they had a diagnosis or not, met diagnostic criteria for MECFS. And then, of course, even more strikingly for me, we found that 4/5 of them, of these patients with fibromyalgia and MECFS, in fact, had clinically significant hypermobility, and that various hypermobility features, in fact, predicted their pain and fatigue scores. So we were also interested in inflammation. And some of you will have been to the doctor and had inflammatory blood tests, and you will have had things that GPs can do, like CRP, C-reactive protein, and ESR, erythrocyte sedimentation rate. And it was thought for a long time that fibromyalgia and MECFS were not inflammatory conditions, that inflammation was completely okay. But what we showed in this study was that the patients had significantly higher levels of inflammation than the controls. But what it was that this inflammation was basically at what kind of the borderline of what is considered normal and abnormal, but the controls really had no levels of inflammation at all. And we found that the inflammation levels also correlated with the pain and fatigue levels. And so what we were interested in is what happened when we put people on the tilt table. And as you can see, patients in red, controls in blue, that the patients had increases in pain and fatigue on the tilt table, whereas the controls really didn't. And what was interesting is that in the patients, there was no difference in pain threshold on tilt. So it wasn't that they'd become more sensitive to pain, they were experiencing more pain. So again, back to the mathematical diagrams, what might be explaining this relationship? So what we found was that if you were a fibromyalgia or MECFS patient, you were more likely to experience tilt-induced pain, and that was related to underlying joint hypermobility in terms of the number of connective tissue features. And if you were a patient, you were more likely to experience tilt-induced fatigue, and that was related to your baseline level of inflammation. So we quite neatly showed that the interaction between the inflammatory system, the autonomic system, and connective tissue. So when we brought patients into the brain scanner, we and they had the typhoid vaccination, we showed that in the patients compared to the controls, they had greater inflammation-induced pain, greater inflammation-induced fatigue, and that actually a feature of hypermobility, so some hypermobile people, not all, can do this sort of thing, where you overlap your thumb with your little finger, or you can protrude your thumb the other side of your wrist. It's called arachnodactyly. which means long spidery fingers. And what we found was that the relationship between being a patient and experiencing increased inflammation-induced pain and fatigue was related to changes in the body in terms of your inflammatory response, but this was further related to whether you had this particular hypermobility feature. And we wonder if this feature is a subtype of hypermobility that may has a particular inflammatory response. So looking at the brain images, we looked to see how different parts of the brain talk to one another, both before and after the inflammatory challenge. And and what we found was they were different, the talking bits of the brain to one another in terms of the strength of those connections were different in the hypermobile people compared to the non-hypermobile people. And that the change in this brain talk induced by the inflammatory challenge was explained by the connective tissue features. So again, you see how this is all interlinked. And what I presented to you is actually a huge amount of work. And so I just want to briefly thank all of the people who took part in that study. It took about 4 or 5 years, and there were lots and lots of people involved. So we've been doing other work alongside this. So we were thinking, because as you know, we've been thinking about hypermobility and neurodivergence. So if hypermobility is such a big thing in chronic pain and fatigue, might neurodivergence be a thing in chronic pain and fatigue as well? So my colleague Lisa Quat, she got some money to study this. And what we found was that having neurodivergent characteristics, so traits on an ADHD or autism screening questionnaires, predicted being more likely to have chronic pain and fatigue, and that was in fact explained by joint hypermobility. So alongside doing all of this work, suddenly we have COVID, and then we have long COVID. And we're wondering, there's a lot of people in support groups with long COVID who are neurodivergent. I speak to a long COVID conference about hypermobility and pain and fatigue. And when I'm there, I meet a researcher at King's College in London who was instrumental in setting up something called the COVID Symptoms Survey Biobank, which was launched off the back of the Zoe app back in 2020 and was collecting data about people's COVID experiences. So what we did is they added that 5-part self-report questionnaire to one of their systematic questionnaires, where they already know about people's COVID experiences. And we are due to publish it's been accepted for publication, the findings of that study. And what this study suggests is that if you are likely hypermobile, you're more likely to experience long COVID, even if we account for things like vaccination status, education status, socioeconomic status. There seems to be a link between hypermobility and long COVID. And furthermore, people with long COVID seem to be more likely to develop postural tachycardia syndrome, which we know is closely related to joint hypermobility. So why is it important? I mean, you thought you were coming to a talk about ADHD, but this has been quite a lot about the body. Why is it important to think brain body? Well, anyway, Embracing Complexity, which is a coalition of neurodevelopmental charities, they surveyed their members, and they found that nearly half of neurodivergent individuals felt their treatment of a mental or physical health problem was worse because they were neurodivergent. We've done work in Sussex Partnership where we've talked to neurodivergent people or people with physical health problems, and people tell us that they struggle for years to get an assessment and diagnosis for both mental health and physical health problems, that they feel a strong sense of being dismissed, misbelieved, or overlooked, especially when interacting with professionals and institutions, and that they repeatedly encounter poor understanding and few or no adjustments for their needs within healthcare and education settings. And I think we really must bring both the brain and body together to think about where we're going wrong and what we can do better. The thing is that our conventional treatments, they might not work for all in terms of drug treatments or psychotherapy treatments. And so thinking about brain and body opens up novel avenues for personalised interventions that might be bodily based for common mental health problems. And I just want to, for any of you in the room who have a hypermobility diagnosis, it may have been really hard to get that diagnosis, just as it's really hard to get an autism and an ADHD diagnosis, especially at the moment with the state of the waiting list. So the clinician-associated traumatization is real, and people are being done a terrible disservice by not being believed. And this is an article that came out last year, really reinforcing the poor experiences that people, often women, have when trying to seek help for their physical health problems. So we have some exciting projects going on at the moment. In fact, we're scanning the last one tomorrow. We're looking at the neural mechanisms of brain fog. So we're applying an autonomic challenge, a challenge to the flight and fright nervous system in the brain scanner in real time, and looking at changes to blood flow in the brain. Our academic clinical fellow colleague, James, he's been doing work about flotation tanks and fatigue. And our PhD student, Beverly, is working on brain fog in pregnancy and the menopause. So I think you've heard enough from me talking about science, and we will just quickly go over to questions. But before we go over to questions, I have to say a massive thank you to all of the funders who have contributed to this work. It's about £1 million worth of work, and all of the participants who have taken part in our studies, all of our research staff, colleagues at the members of the Sussex MECFS Society, Remember and SEDS Connective, our imaging centre at Brighton and Sussex Medical School, the research unit at the county, and my dear colleagues. And I won't mention them all, but I want to have a big shout out to Professor Hugo Critchley and to Dr. Lisa Quat. Thank you so much. I'll stop sharing.
Thanks very much, Jess. That was amazing, really interesting. I know my daughter's funny enough, my middle daughter, she's 7. I'm getting her assessed for ADHD, and she's very much hypermobile. She loves gymnastics and yoga, and yeah, she can do the thing with her hand that I definitely can't. So it's really interesting. It does seem to be from the meetings that I host, you know, sort of this has come up a lot about hypermobility, and it does seem to be definitely sort of a link, doesn't there, between this and neurodiversity. So yeah, really interesting. Thank you for that. Well, we're going to do some questions now. I've got some already that have been sent in, so also get yours, any you have ready as well. You can either put it in the chat, or you can come on screen and ask Jess, Dr. Eccles, directly. I think we've got the first one is from Anthony. Anthony, I don't know whether you want to come on screen. We might, because we had the technical issues, we might have a bit of a problem with that, possibly. So I think what I'll start off this one directly to Dr. Eccles. Anthony asks, I've been trying to disentangle GAD, PTSD and ADD because I've got a big problem with task avoidance, and the NHS help only goes so far. It's difficult to digest a mass of online material. So to simplify, I'm treating conditions as sets of published symptoms. So have people with diagnosed conditions been surveyed to yield more reliable indicators?
Interesting question, Anthony. Essentially, so for people who are not sure, GAD is generalized anxiety disorder. PTSD is post-traumatic stress disorder, which is a form of anxiety disorder. ADD, ADHD. Oh, hello, Anthony. I think one of the problems that we have is that we put people into these boxes, but actually symptoms massively overlap between conditions. And we've been talking about why people with ADHD might be more likely to experience anxiety. It's just one reason, but we know that ADHD and anxiety are more common. I think neurodivergent people are more likely to experience trauma. And I think perhaps because of the bodily differences, neurodivergent people not only are more likely to experience trauma, but they may process trauma differently. And I think this is important to consider. But I think maybe in, I don't know, 10, 20 years' time, our categories may have all changed and we might be thinking different things. Anxiety is not going to go away. ADHD is not going to go away. Trauma is not going to go away. But they all intersect and they lead to brain and body responses. And we need to be better aware of how to manage those responses. So some of the work that we've been doing, and I hope to continue, is thinking about how modulating the sensory system, so getting into a right sensory state, may actually help with emotion regulation, which encompasses anxiety, and also is important, you know, that those flight or fright nervous responses are very important in PTSD.
Okay, thank you, Dr. Eccles. Thank you,
So
Jess.
don't
Anthony, what do you think of that? Thank you for the question, by the way. Really good one. Did that help?
I'm so sorry. I'm going to have to catch up with the answer on the recording.
That's all right.
Zoom was asking me to do things, and the
Yeah,
host
sure.
was asking me to unmute and to put the video on, and the lighting was useless. I think, if you don't mind, if I can just take a step back from that question to one that should maybe be asked before: what constitutes a condition? You've mentioned the advantages of hypermobility and of some neurodevelopmental conditions. Where is the crossover drawn? How is the crossover drawn between what might be interesting personality characteristics and a recognized condition? Is it based on exception from the norm, or is it based on disadvantage to the subject, or are there other criteria?
So the classical view, which is the one taken by the DSM and I think by the DSM-5 and the ICD-11, is that these are, as you described, they are probably constructs on which people fall at different parts along a spectrum. But there has to be a cutoff somewhere. And the way that the DSM says there is a cutoff is if this is having a functional impact on your life. But of course, what we know about these conditions or these differences is that actually they wax and wane, they fluctuate, and functioning labels are actually problematic. So you can be highly functional in one area, but not at all functional in another. So one of the slides that I sometimes put up is from a Twitter handle called Neurodivergent Academic. And the slide is, I can easily give a talk to 200 people, but I can't phone my doctor when I'm ill. And I think that highlights how dynamic things are. And I like the idea of a spiky profile, that we all have strengths and challenges in different domains, and that they are dynamic and they will evolve over time. But the important thing is not necessarily to worry about the conditions. So this is different in the United States, where like healthcare coverage is dependent on the right code in your notes, but is to work out what things do you need support with, and what things how can you thrive? What support will help you manage these differences? Whether they are symptoms or characteristics is a huge philosophical debate. My feeling is that this is a spectrum part of humanity, and that that we all at different parts of our lives experience these things in some way, and that yes, are they differences, disorders, conditions? It's very, very hard. That's really a philosophical idea, but it has very real relevance to the world. I think we should focus on where we need support and how to get it, and also recognizing that people that bodies and brains are different. I suspect many more people's bodies and brains are different than we think. and that it may well actually be typical to be atypical. But that's just my my thinking.
Oh, many thanks.
Yes, thank you, Jess, and thank you, Anthony, for that question. Okay, I'll put another one to Jess from this time. This is from Flo, and Flo's asking, what advice would you give mental health professionals to improve the massive gaps in treatment? Things to consider in terms of adaptions, etc. And she also said, I love your work, and sharing this has been so helpful to myself and clients. Over to you, Jess.
Thank you so much, Flo. I think there's a couple of things. So which kind of puts me at odds with the answer that I just gave to Anthony. But essentially, I think that mental health professionals need to realize that neurodivergence is every mental health professional's business. That we need to recognize that probably a lot of people accessing mental health services may be autistic, have ADHD, combinations thereof, and that we should, and knowing, because we've done some work, I showed you the research from Sweden that suggested 1 in 5 people in CMHTs are likely autistic. We've just done some work at our local A&E department and found a very high amount of likely neurodivergence in people attending A&E in crisis. We have to presume that pretty much everyone would benefit from sensible adaptations. So giving out ear defenders or earplugs in A&E or in busy waiting rooms. I'm just working at East Brighton Community Mental Health Centre at the moment, and I don't know if any of you have been there recently, but there is terrible building work, and it's almost embarrassing to be talking to patients when there is cacophony going on. I think there are simple things like telling people in advance what to expect from an appointment that can be really useful, explaining properly what your plan is, giving people advice in different formats. But the interesting thing about what we think of as neurodivergent adaptations, they'd be helpful for anyone. There's no one who would be harmed by the provision of clear information, of sensitivity to their sensory surroundings. So I think that one of the big problems that we have for ADHD, for autism, and it's got wild in the last couple of years, is that the demand for assessments so exceeds capacity that waiting lists are unmanageable. And they're so unmanageable that in some areas, access to them is being restricted. You have to be, under social services or at risk of going to prison. I don't think that's the right way forward. I think we have to rip up the rule book and basically say ADHD and autism are not specialist subjects, that general psychiatrists, possibly even GPs with the right training, should be able to diagnose. And that knowing that there are so many neurodivergent people needing to access mental health and physical health care services, that we should operate on the basis that everyone is neurodivergent.
Amazing, thank you. I think what you said is probably the bit that is the gap. So I think in my service, certainly I've got a massive passion and my team are really keen and we've been sharing loads of resources, but I think that certainly the people that I see when they've had experiences, whether that be in the hospital or GP surgeries, I think it's a real lack of confidence and a massive lack of training because none of it's mandatory. And I'm just wondering whether there is a pathway in, because it's clearly a gap, around how to get more training so that people have got that confidence and they're not just, I suppose, just feeding into the problem, making people feel even more shame and all of that stuff.
Well, exactly. And so I'm privileged to have been able to be part of the Royal College of Psychiatrists has a new national autism training program for all psychiatrists in training, consultants, any specialty, any grade. And I think we are doing a good job about encouraging psychiatrists to feel more confident about autism. But it's not just psychiatrists might lead this charge, but it's actually all clinicians need to be more confident. And that means changing curricula in nursing schools, in occupational therapy schools, It means raising awareness in education. It needs things to change at a very, very high level. And I think in some ways, the UK is actually doing a lot better than some other countries. You hear of stories, you know, about the shame around autism in the US and things like that. And I do think the UK is doing a good job. But these issues need to be everybody's business. And making it, you know, this ivory tower of specialist services that never talk to other services is just, and also, I mean, I'm sure some of you will have found your lengthy diagnostic reports very helpful, but the burden of proof on a neurodevelopmental clinician to prove that someone has a condition is unlike any other condition. If a patient came to me and I thought they had bipolar disorder, or I thought they had psychosis, or I thought they had PTSD, I'd maybe write a 2-page letter and I would be entitled to my clinical judgment. But for me to say, oh, someone has ADHD, or to say, I think they are autistic, there is this burden of proof of, you know, 15 pages of letter. And that is holding us up as well. The fact that everyone has to be seen in ADHD clinic on a yearly review, that is clogging up clinic. We need to let GPs.
Also just really offensive as well, having to prove that you can get a medication, just to be able to go to work, like some sort of drug pusher.
No, so I think we have to think, what is this about? Why are these conditions so special? I mean, obviously, everyone in the room who's neurodivergent is, you know, special. I mean that in a lovely way. But I think, but why are these different to other diagnoses?
Amazing, thank you.
Thanks, Flo. Hopefully that was useful. I'm going to put another question, but just a quick one. Jess, you mentioned the DSM-5, and I can't remember specifically if you just defined that, but it's a really important one. So I just thought I'd say that for everyone listening, the DSM is the Diagnostic and Statistical Manual, version 5, and that's the thing that psychiatric professionals use to diagnose mental health, ADHD, dyslexia, ASD, etc. I just thought I'd put that. I think you may have clarified that, but I know that came.
I didn't. It's a diagnostic framework. It is in fact inherently American, and outside of America there is also the International Classification of Diseases 11. The important thing is that the distinction, so it's different iterations of this manual, and the difference between 4 and 5 was that you could diagnose, it got rid of Asperger's, and it also said that you could have a diagnosis of ADHD and autism together. But it's also, you know, and this is back to Anthony's question, actually. The DSM is useful for insurance codes, and it's, you know, it's helpful in lots of ways. But homosexuality was in the DSM until 1987. And we may be in a situation in, you know, 1987 from now forwards, where neurodivergent conditions are not in the DSM at all.
Oh, okay, Jess. Yeah, because they are. I gather DSM-6 is sort of imminent, isn't it, at some point soon?
I don't know. I think it probably will be a little while.
Yes. Yeah, I think imminent in their terms is probably not the same as I would mean imminent, definitely. But yeah, DSM-6 will be interesting, won't it? Okay, thank you, Jess. Okay, we've got another question, this time from Emma, really interesting one about exercise and diet. And she asks, what exercise and diet is most recommended for EDS? And how can we find out more, get more support with this condition? Thank you, Jess.
So I'll answer the second bit first. So there are several hypermobility charities and support organizations. So there's the HMSA, their website is hypermobility.org, and there's also the Ehlers-Danlos Society UK. And of course, in Sussex and internationally, there is sedsconnective.org, which looks at the intersect between hypermobility and neurodivergence. And there are lots of resources. I think the important thing with exercise for EDS is it is important to move. EDS is one form of hypermobility. All people with EDS are hypermobile, but not all hypermobile people have EDS, which stands for Ehlers-Danlos syndrome. It's important to move, but it's really important not to overdo it. So I think things like gentle structural Pilates can be really good, swimming. But there is a temptation to overdo it, do yoga with really, hyper extended positions, and also to get into boom and bust cycles. So I think in some ways, and we all know with ADHD, the important thing is to build exercise into a routine. So if you can do a little bit, but it's part of your day, that is much better than having one day where you decide you're going to go couch to 5K in the weekend, and then don't do anything for ages, and you get everything out of whack. So taking it slowly, building up gradually, but trying to incorporate it into your routine is really important. And I would say that things like Pilates and swimming are really helpful. In terms of diet, I'm a little skeptical about the idea of, particular diets for particular conditions. Obviously, if you have celiac disease, you should avoid gluten. But I think it's about everything in moderation. And we also know that neurodivergent people, whether they have ADHD, autism, Tourette, often have a lot of texture, food issues, sensory sensitivities to food. That means that diet is difficult. And also, we haven't talked about this could be a whole other webinar, but about the overlap with disordered eating. So I wouldn't want people to kind of latch on to any particular idea that there is a magical diet, because I don't think there is. But I think trying to get some vegetables, some proteins, some fats, some carbohydrates, and really looking after yourself. We know that people with ADHD, autistic people, they struggle with interoception. They might go all day without eating and then suddenly be ravenously hungry. And, suddenly, even though the fridge is full, they can't see inside it because of the door, and it's easier to order a takeaway. So trying to make time for looking after yourself and having good food, I think is important.
Thank you, Jess. Thank you. Okay, we'll move on swiftly because there's quite a few. Thanks for all your amazing questions. There's loads, so I'm gonna try and move fairly swiftly on with these and get on to some of the chat ones. So next is Annabelle. Again, mind blown. There's Jess. People are saying how wonderful the talk's been. She says, mind blown. This is amazing. Is there anything we can physically do to help people like me that are ND?
You mean, I think that's absolutely fine about not wanting to go on screen, but I think trying to raise awareness. If you are ND or hypermobile, write to your MP, bang the drum. It's unacceptable that there are not the services that people need. Just spreading the word as much as possible. Trying to make the most of educating yourself. It's unfortunate that the burden really is actually on the patient, it seems, to educate the doctor rather than vice versa. But arm yourself with the resources. So when a doctor says to you, oh, you can't have EDS, you don't have a Bateman score of 9 out of 9, you can say, well, actually, that's not the case. And here is why it's not the case. So I think it's awful, but hopefully together we can work to make things better. But that is really about boosting recognition, boosting awareness, and making it. I mean, obviously MPs are thinking about other things at the moment, but writing to Wes Streeting and saying, what did you do getting rid of a mental health minister or shadow minister for mental health? You've got to have an autism and ADHD minister or something. Do you know what I mean? We need to speak very, very loudly.
Thanks, Jess. Yeah, I know from experience of meetings, it seems to be the average in Brighton to get an ADHD assessment for an adult is more than 3 years now, unless obviously you go private. And I know I've had experience with my GP, and yeah, it's important to educate the GP, isn't it? Because they are general practitioners, aren't they? They're not a specialist like yourself, are they? That they deal with all sorts of medical issues, and so they
They
won't
deal
necessarily
with
be the experts on neurodivergence and neurodiversity. So
but they deal with all sorts of difficult, complex issues. With the right training, there is no reason to suggest that they shouldn't be able to deal with AD.
yeah, absolutely. Yep. Okay. Thank you, Jess. We've got 3 from Olaf, but I've still got loads in the chat, and we're a bit short of time. So, do you want to maybe just pick one that is the most interesting or piques your interest? Maybe?
I have to say, I'm afraid I don't know what cognitive disengagement syndrome is. It's not something that I've
Okay.
heard of. And although you sent me this question earlier, I was in clinic and didn't have a chance to look it up.
Okay, that's fine.
I presume it is a social communication difference.
Yeah, I hadn't
Uh,
heard of it either, actually. So, what about the second question about
Well,
minor seizures?
traditionally, we know that, well, as I said, autism and ADHD overlap. I mean, they're probably, how we conceptualize neurodivergence will probably be different. It has long been touted that the main physical health correlation with autism is epilepsy. But the degree to with which that is strictly true is uncertain. But we see lots of people, more people than you would expect in with neurodivergent conditions who do have epilepsy. As neuroscience has moved to a dimensional view and the rate of co-occurrence is high, what is the outlook on integrating the available care? Well, that's so important. So some of these services, ADHD services, autism services, were set up when the DSM-4 was in place, and it was like, you went on a waiting list for ADHD, then you went on a waiting list for autism. I think one great thing about our Sussex neurodevelopmental service is it doesn't happen all of the time, but it is we are an integrated service. We offer autism, ADHD, and Tourette syndrome assessments. Never forget about Tourette syndrome. And sometimes, not this week, but last week, I diagnosed all 3 in a single assessment appointment. Someone else in a different part of the country may have ended up waiting about 15 years to get all 3 of them diagnosed. It is, we need these things to change, but I am hopeful that we may be able to. So I am currently, various things like this are sort of are related to the Royal College of Psychiatrists. And this week I've been elected the new chair of the neurodevelopmental pathway. And I am hoping that I will be able to slowly exert some influence in making sure that we, when psychiatrists are thinking about designing services, or that they think about the overlap between ADHD, autism, and Tourette's syndrome.
Thanks, Jess, and congratulations on that. Congratulations indeed. And thanks, Olaf, for that question. Hopefully that answered it for you. And I've learnt a new term. I've just written that down. Thanks, Olaf. Olaf's one of our regulars at support, so thank you for that. Yep, I'll look that up after and come back to you. Okay. Thanks, Olaf. Okay, next, moving on swiftly, we've got Eloise. And she asks, does the fact that there is connective tissue around the brain make it more likely for you to be neurodivergent if you have a hypermobility spectrum disorder? And then she goes on to say, could this fact also be a contributing factor as to why ADHD symptoms can get worse when you're stressed out?
Well, I think this is a really interesting question, Eloise, and obviously right up my street. But of course, there's connective tissue in the brain, and there's a lot more than we thought. So there's things like microglia, which indeed have mast cells in them. So mast cells release histamine. I think that it is quite likely. Well, in fact, this is another presentation. I do have some slides about it, and we are about to publish some really interesting work. There seems to be some influence of the inflammatory system on the connective tissue milieu, which may predispose to neurodivergence, or characteristics being more prominent. We all know that in terms of, you know, if you're ill, you know, sensory sensitivities may be worse. There's various, attention may be worse. There's obviously a huge link, and we also know we know that 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 actually probably what we think of as mental conditions are quite likely considerably immunological. And before I came to be a consultant in the neurodevelopmental service, I was working in the immunopsychiatry service, which is, you know, we were trying to treat people's depression with anti-inflammatories and things.
Okay, everyone, thank you so much for those questions. And thank you, Jess, for answering that in depth. And God, that was amazing. I learned a lot. I'm definitely going to have to, yeah, have a look at this recording, and we will send the recording out to everyone, because I'm sure there's a few of you would love to watch it back again. I certainly would. Yeah, because there's lots of amazing stuff in there. Thank you so much, Jess. Okay, I think we've just got enough time just to do a few announcements and tell you a bit about some of the other stuff that we do that you might be interested in. Just so you know, I think I mentioned at the start, we do, sorry about my spelling there, we do run peer support groups for people with ADHD. And if you want to hear about those, then please join our mailing list, because all of our events basically go through a monthly newsletter that we send out to everybody on the 1st of the month. And I think probably most of you know this anyway. But if you know of anyone that's interested in any of this sort of stuff, or the peer support groups, or anything else we do, then please encourage them to join our mailing list, because it's the gateway to all of the events that we run. Thank you. We're still after, as always, we're a charity. So if there's any help you can give us in volunteering, then again, that's really useful to us. Thank you for coming today. And if you did donate a small amount for your ticket, we really appreciate that. We are a small charity. These cost, well, I was really surprised how much these cost to run, in terms of, you know, the Eventbrite and everything behind it. It's quite horrendous. You know, there's capitalism going mad, especially with a charity. But, you know, we love doing it. It's useful to do it. But if you could help out with a donation in any other way, that would be fantastic as well. And lastly, this is our first webinar of 2024, but we do intend to run some more. We've got some really good ideas for that. If you've got any ideas, or, you know, anything you'd like to see us do, then please let us know. Or, you know, we're on Facebook, there's the website, and you can also email us. And that's it, I think. I'm just going to check the chat. Paul, would you mind just grabbing... Yes, I'll do that too. Yeah, Paul, would you mind just seeing about the link for the mailing list and just pop it in the chat, please?
Yes, certainly will do.
Thank you. Thanks very much. So Paul's going to put that in the chat for me. Thank you, Paul. There's also, yes, thanks for the reminder from certain people. Yeah, we will put a recording. We'll send a recording to you via Eventbrite. Jess, would it be okay to share your slides with the people? Could we do that? Yep, we'll do that as well. So we'll do the recording and that. Paul has put in a link to signing up for our mailing list, and obviously that's also our website as well. And that's it, really. I think I'm done. And wow, timekeeping was great in the end. I think we're literally on the hour. So yeah, just to say thank you so much for attending. Thank you to Paul for all his help with the tech support. It was a bit of a fraught start, and I apologise for that, but we recovered. And thank you, Jess, so much for what was a incredible talk. That you can probably see from the chat. You know, everyone's incredibly, you know, happy and complimentary, and yeah, definitely one of the best webinars I've been to in quite a while. So thank you. Yeah, just lastly, just say thank you to everyone for coming. I say sorry for the start, but we got there, didn't we? Yeah, ADHD moment, but we got it back, didn't we? And we'll send you a feedback form after the event, and if you do get the chance to fill that in, that'd be great. And any questions, just email us at admin@adhdaware.org.uk. And I think, Paul, I think I'm done, aren't I? I think I've done everything.
I
Unless you
don't know
think
if Jess
anything.
just wanted to say something, but
Yeah,
can I
sure,
just
if
thank
you-
everyone for their patience and thank everyone for coming. And I think us three will just stay behind for 2 seconds just
Yeah.
to do the normal roundup afterwards.
We
Jess, did
definitely-
you want to say anything, or was it all good?
Yes. No. I just wanted to say thank you so much for listening, for your patience and your curiosity. We couldn't do work like this without the support of patients, and also we learn so much from your experiences, and there is so much more that we don't understand than we actually know. So it's really invaluable to hear people's experiences, and thank you for all your support.
Thanks, Jess. Thank you, everyone.
Cool. Have a good
Go
evening.
well, be safe, and yeah, we hope to see some of you. I recognise a lot of faces, so I hope to see some of you at the support groups. And yeah, take care, and hopefully see you on the next webinar. Thanks, everyone. Take care. Bye.